Hello, my name is Paul Knaapen. I'm a professor of interventional cardiology at the Amsterdam University Medical Center in Amsterdam. And I'm delighted to host this webinar by ASAHI Intech with my good friends and colleagues, Dr. Leibundgut and Kambis Mashayekhi, on how to develop your CTO toolkit. I think it's a very important topic because when you start embarking on CTOs, obviously tools are essentials. And hopefully within the next hour or hour and a half or so, we'll be able to tell you more about what is essential in your toolkit. So as I just explained, my name is Paul Knaapen. I will be talking about the CTO Toolbox for both Antegrade and Retrograde approaches. Then Greg Leibundgut will be talking about the relatively new wire, the Gladius MG, and what knuckling involves, because knuckling is a very essential part of complex CTO operating. And then the latest innovations and technical insights on retrograde CTO by an operator who needs no introduction, Dr. Kambis Mashayekhi. We will discuss in between among us and at the latest at the end of this session with everything that comes into the website. So please post your questions and we will be able to answer. We will be discussing all your questions that you may or may not have. And then we'll have the closing remarks. So the learning objectives of this webinar is to get a better understanding on the CTO toolbox. I think it is often that it's forgotten that, you know, if you don't have toolbox, you don't have a program. So it's very essential. Learn tips and tricks on what you need to know. Not everybody needs as big a toolbox as somebody else does. So please be aware that whatever your level of complexity is, your toolbox needs to be adjusted, and you need to learn about the devices and whatever is appropriate to your program. And I hope we'll be able to, you know, share some of our knowledge with you in the next coming hour. So my talk will be about my CTO toolbox for both antegrade and retrograde approaches in CTO practice. These are my disclosures. I have none, although I am a big fan of ASAHI products. So as an introduction, I would like to state that we all know that about 1 in 5 of diagnostic angiograms that have obstructive coronary artery disease display a CTO, so it's relatively common, and that we know that throughout the world and still in contemporary practice, the traditional low success rate of antegrade wiring is about 60%. And then thereby we treat these patients differently than non-CTO patients. Less frequent PCI, more frequent bypass surgery or optimal medical therapy. However, this talk is about the toolbox, and the toolbox encompasses advances in wire technologies, both antegrade and retrograde, that has improved success rates significantly. So when you talk about toolbox, when you start embarking on CTOs, there are the basics. First of all, it's dual arterial access. It's virtually in all cases that you need them, apart from those where you need IPSI collaterals and may single guide suffice, but in general, dual arterial access. And also the guiding catheters are a little bit different. Usually larger guiding catheter, 7 or 8 French, as opposed to 5 or 6. And obviously also guide extensions that adhere to the guide catheters that you use. Microcatheters are virtually always used in CTO operating, never without. And obviously we have dedicated wires. Dedicated wires are essential, and this is basically the fundamental of this talk. Also, Intracoronary imaging is important, calcium management is important, latest stent technology to have durable results, and more contemporary drug-coated balloon technology potentially as well. And finally, but not least, be prepared to deal with complications. These are complex PCI situations. If you cannot deal with complications, you should not be dealing with this type of CTO patients. So first of all, guys, think big and support. And I know that we have contemporary about snuff box and radial and moving away from femoral, and it's all fine. But we should realize that a lot of our devices cannot be fitted into 5 or 6 French guides. So 7 or 8 are still mandatory, dual access, whether that be both radial, one radial femoral, which is my approach, or whatever. But be aware that you set up for success and you don't set up for failure. You need large bore guides. Then every CTO starts with a microcatheter. And basically we have 5 types of microcatheter, which I think should all be in the toolbox. It's a regular one, which in my practice is a Corsair Pro, which is a 2.70 French microcatheter. Alternatives would be Turnpike or Mamba or any other type of vendor, but this is basically for an Antegrade approach. Then you have some slimmer microcatheter, like the Corsair Pro XS, which balances between Antegrade and Retrograde approaches. Alternatives could be like Teleflex from Turnpike AP or the Mamba Flex. And then you have the ultra slim microcatheters like the Caravelle and the Fine Cross, which are usually suitable for epicardioles. Alternatively, when you need plaque modification, you have Tornus, or very popular is the Turnpike Spiral or the Turnpike Gold. If your wire has crossed, but your microcatheter won't follow, you need sort of a manual rotablating device, plaque modification device, which you need. And then obviously over the last couple of years, double lumen catheter has gained very much usefulness and popularity with the Sasuke from ASAHI, but also popular are twin pass and enhancer. It goes beyond saying that we need short microcatheters for the Antegrade approach, like 135, and the longer for the Retrograde approach. Keep in mind, obviously, that the plaque modification microcatheters do not apply for the Retrograde approach. So when you take a look at the microcatheters properties, you'll see that when you start Antegrade, I usually start with the ASAHI Corsair Pro. A lot of support, a lot of talkability, a lot of crossability. However, if you take a Retrograde approach, it's sometimes less useful, especially when you take a look at epicardioles. Then you need something slimmer, and Caravelle is the ultra slimmest. It can virtually do no harm to epicardioles, but low profile trackability is good, but support is obviously low, and talkability and crossability also. So the sort of in-between microcatheter is the ASAHI Corsair Pro XS, like the Turnpike LP, which sort of encompasses torqueability and still has low profile and trackability. So choose your microcatheter as you see fit for your patient at that time. So once you have a microcatheter chosen for the patient at hand, you need to choose a wire. And this is a scheme I always use because we used to have a lot of wires with a lot of difficulties. And I always say to operators whom I proctor, choose a set of wires which you become limited and familiar with, as opposed to taking all the sets of wires. So in my common day practice, and this is just like by our good friend and colleague, Dr. Weilenmann, we have 3 types of wires, and we should choose whatever we want. It's a soft polymer jacketed wire from ASAHI. This will be Fieldrex TR and Fieldrex TA. From Boston, it's the Fighter. From Teleflex, it's the sorry, I forgot the name, but it's a soft polymer jacketed wire. Then you have the intermediate types of wires that could either be the Gaia family or stiff polymer jacketed wires like the Pilot or the UV3, and they have the penetrative wires like the Pilot, like the Confiance Pro 12 and the Hornet and such like. Something that is not on this scheme, and this is relatively novel, is the Gladius wire. The Gladius has been introduced in peripheral artery disease and now has made its way into coronary disease. And once introduced to coronary disease, and this is by Professor Lombardi, who needs no introduction, it's like a Pilot 200 on steroids. It's basically a Pilot 200 only with Act 1 technology from ASAHI. And if I could advise anyone to add something to the toolbox, it would be the Gladius wire. It's a stiff polymer jacketed wire with Act 1 technology, and its uses are very versatile. It can drop long segments with relatively low risk of perforation. It does end up in the subintimal space, but if you're comfortable in the subintimal space, as most operators are, it's benign. It can do re-entry. Sometimes it ends up in subintimal space and then re-enters into true lumen without stingray devices or other devices like double lumen catheters to get you back into the true lumen. And it forms a good knuckle as well, so you can even store it. And in my practice, when all hope is lost. So sometimes you're out of options, you start over again, you take a Gladius, it's a stiff polymer jacketed wire from the get-go of the proximal cap, and sometimes you somehow end up in the true lumen. Another that's not on the list is the Estado. It's more stiffer. So if you want to go beyond the Confiance Pro 12 or the Hornet 14, you sometimes need it. When the going gets tough, the tough get going. It's 20 and 40 grams. They're basically non-directional, but they poke pretty good. So if you have a calcified lesion, they may do the work for you for proximal cap or re-entry or whatever. However, it must be used with caution because it will basically go anywhere. So it's not for everybody, but I think it's definitely for advanced toolbox equipment that you really need it. Not 100 on the shelf, but a couple. So when you take a look at the choice of wires, we have like all these guide wires, selection characteristics and torque, support, crossing, flexibility, prolapsing, trackability, etc., etc. But when I proctor, I always tell, okay, just start with a soft polymer jacketed wire. This could be like a Fielrex DA or a Fighter or whatever, just anything soft polymer jacketed. And if that doesn't work, if you know the course of the artery, you need a directional wire, and that would typically be the Gaia family. And if that doesn't work, Confiance Pro 12. If you don't know the course of the artery, this would typically be a stiff polymer jacketed wire. It used to be Pilot 200, and in contemporary practice, in my lab at least, it would be the Gladius, because it has a rare event of perforating. And once you're in the subintimal space, you can try to re-enter with dedicated equipment. Also, when you start embarking on CTOs, polymer jacketed wires are safe. This is a slide I borrowed from Professor James Pratt. When you don't know the course of the artery, don't start poking with stiff wires because you may easily exit and cause a complication. When you start working with polymer jacketed wires, they will follow the track and not exit the vessel. We have algorithms which show us which wires or which strategy we should use. I took this slide, which is almost a decade old now, on the hybrid, the algorithm. It's been updated, but I still like this because it tells us basically 4 types of things we need to know. what does the proximal cap look like? What is the lesion length? What is the distal target? And do I have retro options? And in your contemporary practice, you need to think about what your strategy should be. If you encompass both antegrade and retrograde strategies and ADR and RDR, you can really simplify this scheme. And I think the length of the target is no longer an issue with the advancements of wires as we talking about today. So, is it ever too long to try to wire? Well, this is a case I did a couple of years ago, and it looks like a really, really long lesion with relatively good retro options, with relatively good septals, about 10 centimeters long, but the proximal cap is pretty good. So if you would adhere to the lesion length, you would say, okay, I'm going to go for dissection reentry immediately. However, when we took a polymer jacketed wire, whether that being a Fielder or a Gladius or whatever, it just went. So it's never, you know, in Amsterdam we say if it doesn't work in 2 minutes, it's not going to work in 2 hours, but this works in like 40 seconds. So please always try antegrade approaches, even if you think it's not feasible for a short attempt, because it can really simplify your procedure. If it doesn't work, you'll scale up, if you know the course of the artery, to directional wires, like a Gaia family wires. This is a typical example we did somewhat days ago. It's a circumflex artery. You have a clear proximal cap. You have a distal target that's not good for reentry. Retro options were poor. We started with a soft polymer jacketed wire. This is a Fielder XTA. We clearly ended in the subintimal space. We could have popped in a Stingray, but instead we took a directional wire like a Gaia, and here you see actually the pop from the subintimal space into the true lumen. So this is something that needs to be involved in the whole algorithm that's not described, how to get reentry from subintimal space wire-based. Reconstructed the left main with culotte, and patient is doing fine. However, antegrade wiring is fine and it's great. However, when you take a look at the recharge database and much databases around Asia and the United States, we can see that in the low JCTO score, antegrade wiring is fine. However, in the high JCTO scores, we know that we need alternative types of crossing, and this is predominantly with retrocrossing. So retrograde wiring escalation is often more successful than antegrade wiring escalation because the proximal cap is often blunt and calcified, whereas the distal cap is often dome-shaped and soft because it's not being exposed to systemic blood pressure, except for those with bypass surgery. We have interventional collaterals, either by bypass grafts, septals, or epicardiols. Bypass grafts are usually easy, although it may be having an angle that's unfavorable. Septals are usually benign, and even if you don't cross or perforate, they have a limited consequence for the patients. Epicardials, obviously, if you perforate them, you will get dampened out. So if you need a toolkit for septals and epicardial crossing, it'll be the ASAHI Sion with the Sion Black or the Fielder XCR, and in more contemporary practice, also the SUO 3. These are basically the 4 wires you need if you want to get retro. So I'll show you one slide example. This is an RFE branch of a patient with ischemic cardiomyopathy within the CTO of the LAD. And this is a Caravelle and a SUO 03. It's what Alex and I have deemed to call the epicardial combo kit. So finally, in conclusion of my talk, I'd like to show you something of a patient which all encompasses. This is a diagonal disease. This patient had not been treated. They've been refused revascularization by many centers because of a small diagonal, yet he had angina when cycling on a bike. And you see the diagonal. So finally he was referred to us, and I said, well, I'll give it a go. Well, I have to get a retro. I have no proximal cap. So this is a Caravelle. This is a selective injection. This is a suo going from the LAD to the diagonal. This is passing of the suo. This is a tip injection to see where I need to go. This is then wire escalation, and finally I needed the Confiance Pro 12 to get back into the lumen. As you can see right here. This is then externalizing after getting back into the true lumen. Verification with IVUS of the intracoronary exit and entry point of the wire, and then reconstructing the artery. The patient has been doing fine. Obviously, this is not for longevity, but he's now off of anti-anginal medication and is doing well. So in conclusion, I'd like to state that CTO PCI is complex. It requires skill and training. Dedicated equipment is mandatory. Toolbox have a basic set of needs, and you need to fill your toolbox to whatever complexity you are about to embark on. And stay updated as innovation is ongoing, and get familiar with the tools you need. So, any Kambis, Greg, anything to communicate about what I just talked about this toolbox?
Sure, Paul. First of all, thanks for this really great overview. I think it was very interesting, especially for the attendees as well. So, Paul, when you look at all those different wires and microcatheters nowadays, and this is often a question coming up as well from the industry towards to us and to the operators. Do you miss anything? I mean, for your toolbox, especially regarding wires, do you miss any wire? Could you imagine a wire where you say, this is something that I would like to have, but it's not invented yet?
It's a good question. And if it were like 1 year ago, I would say yes, I would dedicate one wire in which I could solve a lot of problems, but the Gladius sort of did it for me. I once had a discussion with Bill Lombardi in New York. If you could choose one wire, just one wire, in which you could solve everything. If you were like in Africa and nothing would be available, which wire would you take? And his answer was Pilot 200. And I think this answer now has been replaced by a Gladius. A Gladius is a versatile wire which you can use for most of instances. I'm not an engineer, and I don't know which other types of wires I would like to have, but I think the Gladius really has been a game changer in terms of solving problems where you would otherwise not see them.
And another question, when I see you now doing this kind of epicardial stuff on ipsilateral cases, you know that I already did this very early when we did not have such comfortable wires and microcatheters, and for sure the risk was higher. I do think based on those, let's say, epicardial toolkit box, what you have now with the Suicide Free and Caravelle, that you can go a little bit further regarding epicardial crossing, or did it change anything? I mean, especially when you look at the last case, in comparison to an old Xeon wire with probably, I don't know, fine cross, or what alternatives did we have in the past? Do you think that this, based on Caravelle and suicide free, that you can do more epicardials in a safe way, which may increase safety and also success rate?
Yeah, so it's an excellent question, and there are two answers. First of all, is if I would choose a Antegrade dissection entry over epicardials that are unsafe in deemed of the operator anytime. So always explore your ADR options. But if there are none, I'm very happy with Caravelle and Suo, because in general, the Suo tends to break before the artery breaks, before the collateral breaks. So the Suo would tell you when it's uncrossable. The Suo would prohibit you from complications. The Suo will not easily cause a perforation, because it will just easily break. If the Suo breaks, you should stop. And I think that's the wise lesson. So it makes me embark more and more on Suo right now, because if the Suo doesn't want to go, probably the artery has little negotiation to comply with. That being said, I would like to give the hand to Greg. Greg, could you share your screen and give your presentation about the novel wire, Gladius MG?
Yeah, so Paul, thank you very much for your kind introduction and your great overview on dedicated tools. And I really agree that we should use most of them, but also agree that there's different categories of tools, wires, microcatheters. Some are interchangeable and some are really unique, like you just outlined the Suo. I think that's a unique wire. There's no copycat of that as of yet. And that brings me to my talk today about perfect knuckling with the Gladius MG, which is a extension of the Gladius X, which was the initial Gladius, which is, I think, an improvement over a Pilot 200 with a pre-shade tip, a little bit different tip load. And now, you mentioned it, Bill Lombardi invented the Gladius Mongo, how it's called in the US and in Europe, and I think the rest of the world would call it MG. It's a little bit of a different Gladius wire, and I think it's also a game changer in some sort, like the Suo. So looking for knuckling techniques, first of all, this is one that I use almost every month because I can still not remember which month has 30 and which one has 31 days. That's not the knuckling technique that I'm talking about today. Also not this one, which is maybe more Japanese knuckle technique. It shows you how much water you have to add to the rice in order to cook it nice and soft. But what I'm talking today is the knuckle technique in CTO PCI. It's less a Japanese technique, although it's a Japanese wire. It just comes more from the US side, where they did knuckling with the Pilot 200 and also then the Gladius X, and now Bill Lombardi invented that new MG wire. Just briefly, the knuckle technique is used to create a deliberate blunt dissection plane in various CTOs techniques, and we can then safely maneuver the wire in those blunt dissection planes, which are still in the vessel architecture downwards and hopefully around the calcium. The guide wire used is usually a polymer jacketed guide wire. As I said, it is pushed until a complex loop forms and then advanced through the lesion. This is also represented in most of the CTO algorithms, and I just had the Euro CTO algorithm, but I changed it to the recently published global CTO crossing algorithm. And it basically shows you that whenever Antegrade wiring fails, you will then end up in an Antegrade dissection and re-entry strategy. And if this is wire-based, you will be using knuckle wiring. And also in retrograde approaches, usually when you cannot retrograde wire the lumen, the true lumen, we usually use reverse cart maneuver, and the latest version would be with the retrograde knuckle coming from the subintimal space. and entering into this subintimal space opened up by the antegrade balloon. So in general, you can say that whenever there is a long CTO that you cannot wire, there is severe calcification that brings your wire out of the lumen into the subintimal space, or if you have an ambiguous vessel course, or all three of them, it's time for ADR and wire-based knuckling. Paul already outlined it. Knuckling is something you do with polymer jacketed wires because they're the most slippery wires. And here I want to outline a little bit more about what is the knuckles physics. You're all familiar with the tip load of your wires, and this is just an overview how we measure tip load. So we clamp the wire about 10 millimeter behind the tip, and then vertically push it onto a load cell, and then we look how much the wire deflects. And the stiffer the wire, the higher the force you can bring on the load cell, and if it doesn't buckle, it's stiffer, and then you can therefore achieve a higher tip load. As you also know, we have different guide wire tips. So we have non-tapered tips on your workhorse wires. We have tapered pointy tips on the Gaia family very much, but also a little bit on the Pilot. We have tapered round tips on Fielder XTI and XTR, as well as the penetration wires. And we have tapered pointed tip, like the Stingray, which is almost like a needle. And almost like the analogy with high heels. So if somebody steps on your foot with a sneaker, it's probably not as dangerous or as pointy as when somebody steps on your foot with the same weight with high heels. So therefore, we are talking about penetration power, so penetration ability of that tip of the high heel through your foot in this analogy, and in our space, the penetration of the wire into the calcium or the lesion. And penetration power is a function of tip load divided by tip area. Therefore, when you have a very tip loady wire and you have a pointy tip at the same time, you will end up with a higher penetration power than when you have the same wire with a rounded tip. And here you can see in comparison a workhorse on top, and in the middle, that's a taper tip Confianza Pro, and then at C, that would be the Pilot 200 with that pointy tip. And you can imagine that you have a higher tip penetration power, even though the tip load is only around 4 grams. When we have this high penetration power, is something we don't want when we do knuckling, because we want to stay in that dissection plane and we don't want to perforate through the layers of tissue outside of the vessel into the pericardium or any other space. And therefore, what we want to know is a high tip load, but not a high penetration power. Therefore, on the opposite, and make the point tippy, the tip pointy, we need to have a large tip surface area, and that can be achieved by folding the wire, and therefore having like basically twice the tip area, and reducing your tip load or your penetration power actually by half. This is what happens when you do knuckles. On top of that, we have the polymeric coating, which makes the wire also slippery and less rigid and more likely stay in the architecture. As outlined here, where you have a green wire with a high tip load, non-polymeric, that would just go straight in your first bend. Imagine the proximal RCA, whereas we have a polymeric wire with a knuckle that follows nicely the vessel path. And some quote also here, this is from Bill Lombardi. Besides PLF, which I'm not going to translate, he also always told me, Greg, trust the knuckle. And this is really something that translated into me and that I try to also tell my proctored cases. I think you can really trust the knuckle, except when it exits into a side branch, you can end up with distal vessel perforations. Therefore, you have to be careful. But you can distally perforate the vessel with any wire. So always watch your wires, but when it stays in the architecture, a knuckle is really safe. And I've never had a ruptured vessel, big vessel, just because of the knuckle. Once you dilate and you stent, that's another story, because you're in a subintimal space with thinner layers of media on one side and calcium on the other side, but I'm not going to talk about that in my talk today. Guide wire support is also something really important. The more supportive your wire is, you can imagine the higher your tip load, the theoretical tip load will eventually be, and therefore it affects the shear force of your knuckle wire. So when you have a Gladius extra support, it would have a more penetrable or more powerful knuckle than if you have just a Fielder XTA, for example. There's a few different types of knuckles. These are just images from some of my cases. On the left, it's tiny, then you go to small, large, and sometimes huge knuckles. The tiny knuckle is even a magnification, so you can appreciate the tip of the Antegrade Corsair in that case. That was a Fielder XTA that I used previously for knuckling. And you can see it forms a tiny knuckle, but you can also see that behind the knuckle, the wire already starts buckling. That's because of the less supportive shaft. This is not very strong knuckle. It works a lot of times, but in very calcified lesions, you can end up failing with that. Then the small knuckle is a Gladius MG. And you can see that it forms a nice, small, and very controllable knuckle. Then the large one was a Gladius X in heavy calcified lesion, and the huge was also Gladius in a kind of a ridiculous post-cabbage patient with, I don't know how many tons of calcium. But still, even that knuckle stayed in the vessel architecture. I had no perforation. Also, the knuckle size shows you how big the vessel is. You have to be careful, it's not the vessel lumen, it's about threefold the vessel lumen. So the vessel architecture size is about threefold the vessel lumen. That's how big your knuckle can become. After knuckling, the Gladius and also the pilot permanently deform. Here you can see the Gladius EX from the case that I had these huge knuckles, and I had to use actually 4 or 5 of these Gladiuses until I got through the lesion. They started to do huge knuckles and deform, and I had a hard time to even get them back into the microcatheter. Gladius MG is the only wire that can be reused for rewiring after knuckling, and I'm going to show you that a little bit later on. Tip retention is excellent and really unique on that wire. So in general, I told you already, polymer jacketed guide wires are the wires to use for knuckling. When you want to have a large knuckle or more penetration power, you use the pilot, the Gladius X, or the Raider. Smaller knuckles are formed with Fielder and Bandit, although I think the Bandit is too weak to even try to do knuckling technique at all. And then nowadays we have the powerful intermediate knuckle and well-controllable knuckle of the Gladius MG. And here are the two wires in comparison. On top, the Gladius EX with a tip load of 3.0 gram. Same for the Gladius MG, with the difference that there is a micro gap a few millimeters behind the tip. Both wires have pre-shade tips, and this micro gap actually enables the wire to knuckle as soon as the tip feels some resistance. It falls over, and you will end up with a nice, small, controllable knuckle. Here again, you see the comparison between Gladius in yellow and Pilot 200 in blue. And you see why the Gladius forms this much shorter, about 8 millimeter long and very tiny knuckle, because the step up of the load of the core wire is immediate and abrupt after about 6 to 8 millimeter. And that's exactly where the wire folds. Whereas the Pilot 200 has a gradual increase of that load on the core wire, and it will eventually buckle or fold over at one of these spots up to almost 30 millimeter, according to the resistance of your distal plaque and how much you push. So the knuckles can get really big on Pilot and also on the Gladius EX. Subintimal hematoma is a function of the knuckle size. When you have narrow loops on top left, you can have small subintimal hematoma. And when you have wider loops, you have sometimes huge subintimal hematomas, which then can affect or fill up with blood from proximally if you don't take care and if you don't block the inflow. and then actually close your distal vessel, and re-entry can be difficult until even impossible at all. When should we knuckle? In general, I would say when the wire escalation strategy fails, when the vessel is really tortuous, ambiguous vessel course, ideally there is no side branches for the knuckle to go inside, no distal bifurcation. Also, because when you knuckle, you're by definition subintimal and you can close all the side branches. Therefore, knuckling, I think, is ideal in the RCA and less ideal in a proximal LAD, where you have to take care of the septal and the diagonal branches. Of course, if there's no distal bifurcation, it's easier for the re-entry also if you have a landing zone. Preferably you do retrograde knuckles in modified cart, because you're not propagating the subintimal dissection plane, and also usually because it's filled from distal with lower blood pressure, you don't end up with large subintimal hematomas. Then antegrade dissection reentry, if it's wire-based, it is basically equal to knuckling, and then again modified cart. Dissection reentry techniques are all over the place. You can do them antegrade or retrograde, and as you can see here, marked in red, basically in all section, in the dissection and even in the reentry strategy nowadays with star, mini star, whatever difference that is, last and AFR, it's basically all the knuckle entering the distal lumen. And in my experience, this is really much more easy, or was really facilitated by the Gladius MG with that small, directable and penetrable knuckle. How to get the knuckle going? You first need to have entry from your luminum side to the subintimal space. This could be wire-based with a penetration wire or a Gaia family wire. You can do it balloon-assisted with an oversized balloon, basically a base, power knuckle, S-base if there is a side branch. So any means that brings your wire into subintimal space. You can also do that hydraulically, of course, with the Carlino technique. And once you're in the space, I feel most comfortable when I have a knuckle in front, because I know the knuckle is not going to exit that vessel space. Whereas when you working there with, for example, a Conquest Pro 20 or something similar, you can easily end up outside of the vessel. Once you're in the subintimal space, you maneuvered your way around the plaque. You want to re-enter, and as I said already, you can do that with these techniques that I'm not going to focus too much in my talk. Precautions on knuckling. Never spin the knuckle, because you can imagine it creates a knot, and that's possible if you go antegrade. You just retrieve everything, but imagine you are just past that very tortuous and difficult septal, or even as Paul just showed an epicardial collateral, and you have a knot on your knuckle. You have to retrieve the whole system, the knuckle outside of your microcatheter, and shear it through your septal or epicardial collaterals, and that can damage your septals or epicardials and cause real troubles. Knuckles tend to go into side branches. I said that, and there you have the risk of perforation. So make sure that you know your vessel course, or that it actually makes sense in ambiguous course of a proximal right. For example, you can check if it's going to the right distal portion and not into an RV branch, for example, on an RAO projection. Big knuckles can weaken, rupture the vessels, not during knuckling, but once you balloon the vessel and stent. So don't oversize these balloons, and check first for small perforations. Small knuckles can cause distal perforations, again, in side branches, as I said. Then knuckles with non-polymeric wires, especially penetration wires, can damage the microcatheter. These wires are not meant to knuckle. Of course, you can knuckle everything. You can knuckle your guide, your microcatheter, whatever you want, but knuckling is a prerequisite for polymeric jacketed wires. In general, knuckles can cause large subintimal hematomas, and there are also ways to reduce those. First, block them, of course, and then also straw the blood from the hematoma. Not part of my talk, but there are means to get around those issues. How to knuckle again? 4 simple steps. You push your wire, your polymeric jacket wire, until it hits some tissue and it forms a bend, and then you just keep on pushing. It's a little bit counterintuitive against whatever you do else in your cath lab, but just trust the knuckle, keep pushing, it buckles, it forms that loop, and then remember, keep pushing and no rotation, and then at one point your knuckle will move and you can follow with the microcatheter. This is an example from a case that I did. Back then I was also using Fielder XT for knuckling. You can see we passed already retrograde and we were in the distal RCA with the microcatheter and the Fielder from the retrograde. And here you can see the Fielder forming the knuckle. First it bends, and I kept pushing, and because it is too weak, because of the penetration power to being too weak, it forms another loop and another, and there at the 4th loop, when there is more push from the core wire, you can see here the knuckle advances, but it gets pretty big, and so I stayed there with the knuckle at that point, and then tried to come up from Antegrade. Still tried to push here, but it didn't work. So then I came from Antegrade with the Gladius MG, and you can also see it's a Gladius MG because it has this only very short radio pack segment that is different to the pilot, and you can see it folds this nice, much smaller and more powerful knuckle, and it joins the retrograde Fielder at that spot. And then you can retract the Gladius from Antegrade, and it has this really nice tip retention folding, and it's almost like a fresh wire when you take it out from knuckling, and you can enter in that RB branch, even being sure that you are in true lumen and not even in the subintimal space anymore. Here you can do a lot of things, do a dual lumen catheter and wire Antegrade, but I think I just wired it and finished the case. That's another case with retrograde wire passage with the Suo Black going into the mid RCA and then an RV branch, then followed with the microcatheter, and then it was time to knuckle retrogradely. Here you can see coming up with the Fielder, and the Fielder again did the small knuckle, then a second bend, it was probably going a side branch and another knuckle, and it's almost like a cauliflower starting there, and you can imagine that you have a huge subintimal hematoma. It's retrograde, so not so bad, but that's something you don't want to have. Few minutes later, or I don't know how much later, I was not able to exit retrogradely, and then I advanced an Antegrade Gladius into the subintimal space, also advanced an Antegrade balloon, had a wire in the conus branch for more backup, and then I did a retrograde cart, modified reverse cart with the Gladius MG. And again, here you can see that really nice, small, controllable knuckle of the Gladius MG, then eventually entering into the subintimal lumen from the balloon while retracting. And then the same case, I was doing contemporary reverse cart, so advancing a guide extension. And you can see this is the very same Gladius that I just knuckled up, and it has a very nice tip retention. I just pulled it back and entered into the guide. Then I could even do a tip-in on an Antegrade microcatheter with the same knuckle Gladius, which is not possible with any other knuckle wire, and then convert antegradely here and then finish the case. This is another case where you see the Gladius. I just want to show you the difference of the knuckles. Of course, we were subintimal, but the knuckle stays nicely, small, low, close to the vessel, and there is no space for subintimal hematoma, and you can follow with your microcatheter nicely. And if you cannot enter, you can usually even just advance the micro, exchange for an extra support wire, and do a stingray antegrade dissection re-entry maneuver. And you don't even need a crossbus in most of the cases, because the knuckle is so small and so nice. I think I have one more case I want to show. Just let me jump forward.
Yeah, because we're running out of time here. I think we should.
Yeah, so then I leave this case off. I mean, it's basically the same thing, comparing fielder, which does huge knuckles, has low penetration power. It's most of the time really weak. And then you take a Gladius MG, and it increases your power by 10-fold, and it's also more controllable and has nice knuckle. This is the real advantage of the Gladius, and I'm really happy, and I'm using it a lot of times.
Okay, thank you, Greg, for this wonderful presentation on a relatively novel wire. My first question to you, Greg, is this just a knuckle wire in your armamentarium, or do you also use it for any other purposes?
Yeah, before my talk, you were talking about one wire that you take on the island, and it's the Gladius. And I was not sure if you mean the Gladius MG or the X, because for me, it's probably...
Let me circle that, because we have a question from the audience, from Dr. Canova. What's the difference between Gladius MG and Gladius EX?
Basically, they're the same wires. They have 3-gram tip load. They are polymer jacketed. They have the same length, the same radiopacity, the pre-shaped tip. The difference is that there is a weakening of the core 8 millimeters from the tip, which enables the Gladius MG to knuckle and to have this nice, completely folded knuckle. That's the only difference.
Okay, so and then the second question is, that's my question, do you only use it as a knuckle wire, or do you use it for any other purposes as well? The MG, I mean.
Yeah, no, I have both Gladius, and I use it only for knuckling, because I think for doing an antegrade wire escalation, it sometimes starts knuckling when you don't want it to knuckle, because it really forms the knuckle so easily. And sometimes you want to have a directable or a steerable wire. Sometimes I do a secondary bend on the Gladius, which I think it's not good. For the MG, it folds even easier. So I use it deliberately for knuckling. Okay,
and then I have a question for Kambis, because in my practice I try to replace it for the cross boss because it tends to form a smaller knuckle. But it's been, I've had different results on large and small knuckles with the MG as to replace the crossbars. What's your experience in terms of sizing of knuckling as opposed to other wires?
So still I have a, let's say, step up escalation strategy on knuckle wires, which still starts with the normal soft polymer jacket wire like the Fielder XTR series. Because this is almost my wire for when I'm in the plaque, where I try to make some wire escalation, and then I decide between stiffer wire or knuckling, depends on the anatomy. And then I almost try to knuckle with the fielder. So once there is I need more push, then I go to the Sion Black or the MG. Well, this depends a little bit. The Sion Black, the non-radio pack part has a lot of penetration force as well, and can make a very interesting, especially also retrograde knuckle wire. And I almost used it already for the septa surfing, so you can use it very nicely. But I agree that the behavior of the MG is also very good. Sometimes in very, very old CTOs, where I'm not sure about the adventitia and all the anatomical construction, it can end up in huge knuckles. So and loses track. So you have to make a knuckle redirect in this kind of cases. So what happens is that there is some more longitudinal knuckle on the RCAs, which can happen sometimes. So there you have to be a little bit careful. That the knuckle is not getting too large. Nevertheless, finally, after reverse card, you won't see any disadvantage of that as well. Coming back to the question, Paul, regarding where you, if you can use the MG as well as, let's say, wire for navigation, I think yes, it's also very good wire. It's a very good polymer jacket wire with a pre-shaped tip, and if you want to have it with the pre-shaped tip, and can also help for wire escalation strategy as well. So you can decide when you take this wire, you can still go on with let's say wire escalation, and if you are not happy with your wire escalation strategy, you can just knuckle it up front.
Okay, so the final question to you both is if you are not like a dissection reentry kind of guy, either reverse or Antegrade, do you need this in your toolkit? Kambis, yes or no?
If you're not an ADR guy, you need it definitely, because you are also retrograde operator, and saying that.
But also if you don't go retrograde, if you're not dissection reentry kind of guy, do you need this in your toolkit?
Okay, in general, well, it depends on if you are going for, let's say, if you also accept that star can be an option for bailout and investment procedure, it could be theoretically an option, but you really have to understand when you're doing this star or mini star techniques. Yeah.
Okay. Greg,
my answer is no, but you should get to learn ADR, and then yes, you have to have it.
Okay, so after, so it's a sort of it's sort of once you've built the program, this is a useful wire, but not an upfront wire if you don't integrate wiring only. Is that the conclusion?
Yes, absolutely.
Sure.
Okay. So then one final question before we move on to the talk of Kambis. Is it a good wire to re-enter when you're doing a reverse card? Let's say you're doing a guideline and facilitated reverse card, you're very near. Is this a wire you would choose? Yes or no, MG or EX? Greg.
Well, I would not choose it. Let's say I have a wire in place, and then I would exchange it for the Gladius MG to do the re-entry. But usually, as Kambis said, you have it already there. So maybe you're somewhere distal in RCA, you wire up with, and you can use the MG, and you can nicely wire. And then at one point you hit the plaque, and then you just jump into the knuckle mode. And then you knuckle through the calcium, you follow it, you micro, you retract it, and it nicely refolds. And then you can even do the tip in into an Antegrade guide. So you can use it for all these steps interchangeably with just one wire.
Okay, so for reverse card, it would definitely aid in your benefit. Kambis, you?
Yeah, so the difference is not so big, right? That we have to understand. Whenever I can choose, I will try to use the X for the reverse card. I have the impression that there is still a little bit more penetration force there, but nevertheless, it's also possible with the MG.
Okay, so that being said, thank you, Greg, and I'd like to hand the podium to Kambis for his presentation.
All right, so I just put my counter because for the time. Of time. All right. So, well, the last is innovation and technical insights on retrograde CTO. That's the topic. Thanks a lot. So, what I realized is that there are, and we know that there are more and more scores on retrograde channels. So we still have the terminus of non-interventional collaterals and interventional collaterals, but now we're going more and more into understanding determinants why we're not able to wire an epicardial septal collateral. And this is a very nice paper which focus on these problems, let's say, or on complexity on epicardial and septal connections. Well, theoretically, you have to do a super selective injection to get an idea about the bends and about the collateral. And what we know is very difficult are reverse bends. The one reverse bend can, let's say, makes you fail an epicardial connection, and as well the continuous bends are also in a problem. The cockshoe depends on, let's say, amplitude and diameter, but nevertheless, what I have to say is that it's very difficult, and the intraoperator observability, how to interpret this in the G-channel score makes it not so easy. But what we know is that when you have very small vessels, reverse band, continuous band, all this, that you have a high score, and this high score reduce the chance of passing septals, but also non-septal collaterals. So if somebody's interested, you can go through this publication. 2018, there was the first, let's say, or the second publication on collateral scores after Margaret McAntegrade and publication. So, and this was a very good one because it was very simple. In a uni and multivariable analysis, what they found out is that the large size and the lake of tortuosity are predictors for and successful crossing. So having said this, what we understand here is that you get a point for large collateral size, and for excluding tortuosity, there are 2 points. And when you have 3 points, the chance of passing this collateral is very high. So more than 90%. This is very, very interesting. So, well, which is now the best collateral selection? So once you start for retrograde, it's clear we have a clear recommendation. You should start with those kind of septal connections, which are simple to pass, multiple connections, and no tortuosity. So, and you will find that there is a G-channel score of 0 and the Ewing score of 3, based on the fact that there's a large and that there are large collaterals and there is no tortuosity. And when you decide where you want to, let's say, have your retrograde gear, if you want to have it in the posterolateral branch or in the PDA, you have to think that you have to know that the very first septal connections are almost entering, in some cases, even in the posterolateral branch, and the mid-ventricular and distal ones are entering in the PDA. So this is also an information that I want to give you to understand. Well, here you see a septal passage and a microcatheter handling. It's also here a simple cyan blue wire. You see that I just try to find the right way with the wire. Whenever I feel a resistance, I go back and forth. And you see here, finally, it's always in the wrong direction, but now the wire just jumps to the PDA and you already passed it. So now look at the hands. It's about how you bring the corsair down, and what you will see is a clockwise and counterclockwise rotation. Almost here, I rotate counterclockwise, and bring the corsair through this septal connection forward. Here you can see it very nicely. It's a counterclockwise rotation, and the corsair just slips over. So as long as the tip is free, you can just rotate in counterclockwise rotation, but do not over-rotate the device. So if you will over-rotate the device, you might get a corsair fatigue, and this is also not what you want to have. You don't want to destroy the inner coating of the device. So what we know is that there are different microcatheters, and as I was thinking about this, how to explain, and there is a S-twist orientation of the shaft. So which means if you look on the shaft and let's say that the wire is placed here, then you have in this direction, then you have an S, like it's like an S, and it's not a set, it's an S. This is the direction of the outer coil, and which means that when you rotate into the counterclockwise rotation with this S shaft, like the corsair, you will have a thick, you will in counterclockwise, you will have thicker, the device will get thicker and loosen, right? Vice versa, when you rotate clockwise the S shaft, you will have thinner and more tighten. The micro catheter will thinner and will be more tightened. So that's what you have to know about this configuration. Now, regarding the epicardial passage. So, well, I was thinking a lot about epicardial passages and how to do it safe. What I learned is that the control tracking is the safest thing, but if you do a lot of this stuff, you can also in some scenarios go for a relatively fast spinning method when you don't have tortuosity or less tortuosity and you have big collateral connections like this, do super selective injection, and then you can just use the heartbeat and rotate a little bit with your Xeon black wire, and the wire will just jump forward by itself in a way, and it's a very, very fast passage. Here you can see it again of the collateral. So this can be done. What you have to understand while you're doing that is that you never should push at once any resistance. That's very important. But when the wire jumps forward, you can give a little push. So it's more a visual and tactile combination that when the wire jumps, you can give a little bit push, and then you just rotate, and based on the, let's say, movement of the heart, sometimes and with a let's say nearly 90-degree angle in some scenarios, the wire will just jump forward without destroying the collateral. Nevertheless, you should be aware that once you might have a problem, you should have the coils available. And this is what I see as a problematic or more advanced epicardial connection, and which is really a very complex one. It's an ipsilateral one and very tortuous, as you can see here. Well, this is already many years ago, but here you should definitely have some coils prepared if you're going for this kind of connections. Here we did not have any other great opportunity. Probably I was re-entry or passing those kind of collaterals. At this time, there was only Coursera available and only the Xeon Black. Based on the scores, first of all, you have to aspirate blood whenever you analyze this. When you can aspirate blood, you can give a contrast, and then you have to analyze this in multiple views. And what you see, it's a non-septal collateral. It has a reverse band inside. And so this makes already 1 point, probably even corkscrew, we can count it like this as well. So it is an intermediate difficulty or even high difficult. The point is that when you, let's say, classify it as an intermediate difficult to pass, it still can be a high risk. Because why is it high risk? Well, it's a huge one, and if you have a perforation, you may have two problems. First of all, it's a bleeding and tamponade, and the second is it can even risk ischemia here. So therefore, this is even a high risk epicardial connection that you should be clear. So regarding the Huon score, it's large collateral, but we have tortuosity, so the passability chance based on the Huon score is about 70%. So 50 to 70%. It's up of your experience and also about other alternatives if you're going for that or not. So what I did here was, let's say, high risk passage, because after several rotations, the Xeon black wire was not able to rotate anymore in the tortuosity. Therefore, you have to go very close with your Corsair, and when you go so close to the tip, the risk is increasing dramatically. So the first lesson, try to wire the whole collateral without advancing the microcatheter if possible, and advance the microcatheter only if you have a huge, let's say, friction on the wire tip. You can do that with the Xeon black, but you cannot do that with the Suo-03 because the radio part of the Suo-03 can prolapse very easily. So finally, after externalization, everything, a beautiful collateral, beautiful RCA was the end of this case. So this was also a lady, this case was done in Krakow, I remember very well. She had a huge ischemia in the circ, in the LED everywhere, and also in the RCA. And here I failed with antegrade wire escalation. I had not the opportunity at this time because of this, and also no Stingray available as well. There is another PDA, as you can see here. So finally decided to go for this epicardial connection. So what we have to see here is that what you can see here is that there is as well some tortuosity, and the point is that here the wire has some friction. Therefore, what you can see is that there might be a prolapse of the wire in this tortuosity. This is a very dangerous, so you have to stop any fast rotation immediately when you feel a resistance, and here you have really to advance the microcatheter to stabilize the tip of the Sion black. And this has been done here. I tried to advance, but what you can see is a prolapse of the whole system. So rotating in the counterclockwise direction is worked here until I prolapsed. What I did here, I retrieved the device and rotated in the clockwise direction, and then based on the clockwise direction, I was able to take the first curve. So here, so what you can imagine is that there is some pressure on the epicardial connection here, and you have to think if you still can rotate the wire or not. I was able to rotate another band, and then the last band was the, let's say, the important band, and finally I could pass the collateral, and nicely the collateral got stretching. When you are, let's say, when you have no control of your wire here and you would retrieve the wire, the microcatheter tip itself would just crush and destroy the collateral. So here we are on a very, very, let's say, high risk scale of really having a huge problem when you are destroying this collateral. So you should be very careful, or probably not do that. Yeah, I have to say it. So finally, I was able to pass it, and reverse card was done. Everything was preserved, and the lady was okay. So now we have newer microcatheters. Paul already addressed it, and which is a kind of hybrid microcatheter between the Corsair and the Suacer free. It is a very, very interesting device because you have enough pushability, more backup on retrograde approach, and you can also use it as well for antegrade. So saying that, I can show you a case just done some days ago with the microcatheter, and this is how I approach a normal retrograde RCA procedure. And here you see it. So it is, first of all, for sure, I try to do a wire escalation, but what you will see after, let's say, 2 or 3 minutes, I was in subintimal, I just did a knuckle with a very just to prepare antegrade cap, and I have the Corsair Pro XS. I trap out the Corsair Pro XS, and here I'm already with a balloon. And this is very good because the balloon is already prepared here. And finally, you're already prepared for reverse card at the entry of the CTO. So then the passage of this epicardial was very simple. It's a normal Sion blue wire, and the Corsair Pro XS is perfect because here you can just pass it very easily. It is a little bit smaller device and doesn't cause too much ischemia, and also the passage is good. And here still you can rotate the device, and this is the advantage towards the car wheel here. You deflate the balloon, and you're already in the microcatheter. So at the moment, we just use the Filter XT wire and the Sion Blue and the Corsair Pro XS and the balloon. And we are already in the scenario that we have the retrograde microcatheter into the antegrade guide. So now the next is, you can even save the externalization wire that I took the Sion Blue again. I just do the tip in, and this is how a procedure can be very efficient, very cheap, and also very economical. And I think, well, this is our basic approach for RCA. So the procedure took 31 minutes and 80 minutes fluoro time. So it can be very, very fast. So I want to say also a word about the new wire technology, the Suacer free, even if the time is a little bit advanced, but this is an LED occlusion post-cabbage, and I think it's very interesting to see what the new wire technology can do. This is on a Caravelle. This was one of my first cases done in Riga with the SUO03, and this is only possible with this wire, this amazing 360-degree loop, and then also a tip-in was done, and finally the corsair was brought down, and we could stand it and had a beautiful LED. So this is really amazing what the SUO03 can do. Are there any limitations for collateral connections? When do I stop? Here you see a tortuous one. And what you can see here, and I think this is also important to show you, when do I personally stop? So this is the SUO03 engaging here, but finally I was not able to rotate it further based on the tortuosity. So what I need normally here is now a little bit more backup support from the microcatheter. But we know that there is the weak point here of the microcatheter because of the wire, because the wire prolapse. It's a very, very flexible wire, and if you have this shaft prolapsing, then you this is a way where I say, no, I don't go further and I stop here. I also tried the Sion Black, but the Sion Black was not able to pass down. And if it would be a Sion Black, I probably could still take this curve. But with the SUO03, a prolapsing SUO03, it's so weak that it does not give you any stabilization for your microcatheter. So taking together, we have new collateral scores to predict the collateral passage. And we know the predictors for crossability, which is no tortuosity, no reverse bend, and if the collaterals are bigger, it's a little bit better. So how should we pass difficult collaterals? Well, a super selective injection is very important, at least 2 different projections. I think this is mandatory to understand the collateral connection, and you should do a controlled wire tracking. So very, very controlled, never go through any resistance. It's also important, and try to pass the collateral without the MC. If you need the microcatheter, then you should know that you're increasing the risk of perforation. You should avoid the shear stress during the externalization process, and you should stop before the microcatheter prolapse. This is absolutely risky. So prepare for collateral damage and have your coils and which are compatible to your microcatheter. Thank you very much.
Thank you, Kambis, for this wonderful oversight on what is, considered to be the final frontier, even in CTO operating, is to take these very challenging epicardials. A long time ago, when Alex and I were in Amsterdam, when we heard about the combination of Caravelle and SUO, we sort of made it our default setting. We try to refrain from epicardials, but we don't shy away from them if you need to. You've done a lot of work on IPSI, epicardials, collateral. So definitely it goes into, into the hands of what you're used to and experienced, and whether you will or not embark on these endeavors. So
absolutely agree, Paul. Yeah. Definitely what I can tell you as well is that I'm now even a better Antegrade operator as well, and also have I learned also to work on ADR and on IVUS controlled re-entry. So saying that the rate of when I need the epicardial collateral is reduced a little bit compared to probably 2015-16, even if we have better and safer devices. So making me finally a safer operator. Okay, so and when that's good, safety first, but you also talked about like when it goes wrong. So we have a question from the audience. Which coils do you use if something goes wrong? Yeah, so you should use any coils which are 018 compatible, or 14 even better. What I know which works are the Concerto and Axiom coils from EV3. I don't want to say any brand, but it is what I have. And in the past, I also used a bigger coils, but then you need another pro grade microcatheter or something like that. So just find any coil which pass through any microcatheter that you have in your lab, and this is the easiest way to do, even if they are sometimes probably a little bit more expensive, but you won't run every day in this scenario. Probably you need it once in every 2 or 3 months, but then it's essential and it can be life saving, right?
Okay, perfect. So I think it's very wise to say that if you're going to embark on these types of endeavors, you need to deal with complications, as Kambis just mentioned. Greg, another question from the panel. Would you use like a Gladius X prior to any soft polymer jacketed wires, like the Americans most do, like they did with the Pilot 200? Or would you still go for soft polymer jacketed wires as opposed to now just going with Gladius X all the time for any Antegrade wiring as a wire of first choice?
Good question. My first Antegrade wire choice is a Fielder XTR actually, or XTA, which is a taper tip, a polymer jacketed softer wire. And as you showed in your presentation, even though you don't expect it from the anatomy or from the angiogram, it usually or very often just passes and you're done. So that's my very first wire in almost all Antegrade cases. And then I do an escalation strategy, and at one point I think I need a more penetrable polymer jacketed wire. And previously I was using the Pilot 200. There was also Pilot 50, but I think there's no place for that anymore. The Pilot 200 has 4 grams of tip load, is a little bit tapered as I showed, or pointy, so the penetration power is a bit higher. But remember, the Gladius is actually only 3 grams, so it's actually a little bit less tip load wire. But I think it's much better steerable because of the Xion technology of the coils within the wire, and also because of that very nice microtip. So the Gladius EX completely replaced my Pilot 200. And then the Gladius MG, as I said, is then the knuckle version of it with nice refolding capabilities. But that's my step-up strategy.
Okay, so thank you for your answer. So circling down all of this, because this session is about Toolbox. And I think Toolbox is sort of needs to be adjusted to what the operator can do, because basically we have 4 options to open up a chronic total occlusion. It's Antegrade wiring, it's Antegrade dissection and reentry, it's a retrograde wiring, and it's a retrograde dissection reentry. Those last 2 are sort of similar within the incapacity. So I think the Toolbox needs to be adjusted to what program you have. Obviously, we're not talking to you, Greg, and to Kambis, but not in general to the general public. We still know that a lot of programs just still rely on Antegrade wiring with or without double access, but not without retro options, which is okay for the low JCTO scores. And I'd like to ask both Greg and Kambis, would you think that the Gladius and the Mongo, either one or 2, if you just have an Antegrade wire escalation scheme program, which is still the majority of centers worldwide, that these wires will help you? Kambis first.
Yeah, sure. As you know, I really like to start with the Fielder XT R in general. But if I would have only one wire to take somewhere with me, a Gladius would be really a good choice, because I can handle the Gladius very safely as well.
Gladius X.
Yeah, well,
or Mongo.
Well, this is a difficult question here. I don't see too big difference, but regarding, if let's say, if only one wire, probably the Mongo would be the wire without, because you can still steer it in a very nice manner, and you could have a bailout with starring it, and if you would have IVUS, you can even see if you are distally true. before the bifurcation or not, and then you could also stand, right? So it would be an option if you have only one wire available, good gram tip load. Also, if you lose side branches, right, you could wire it. So it is a good wire in general for many difficult scenarios. Yeah.
Okay. So you would advise it also to be within the toolbox for just Antegrade wire specialists.
Yes. So if you have only one wire to choose, I think it would be a good one. Yeah, a good choice. Okay. Very good choice.
You?
Yeah, absolutely agree. Especially a lot of Antegrade operators, they don't have the Stingray crossbus system available, so they're reduced to Antegrade dissection reentry wire based. And there, I think the MG actually improved my reentry rate quite a lot. So I think it's a good tool to have when you don't have access to Stingray crossbus. And if you have that, it's even better because you can get rid of the bus, makes a nice distal space for the balloon. So even if you have ADR Stingray crossbus, it helps you. So I think it's definitely a wire that has its place in ADR.
Okay. That being said, I'd like to close up this session, and I'll go back to my conclusion to wrap up this session. I think it's fairly easy to say that CTO PCI is very complex, and we've just handled the toolbox issue today, but it's more encompassing than that. It requires training, skill and training, and equipment in the toolbox is necessary. But if you don't know how to use the tools, the toolbox is useless. So basically, it needs experience and proctoring, and a lot of us sharing the knowledge as we do at this ASAHI webinar today, which we thank ASAHI for distributing the knowledge. Staying updated is very, very important, because the tools we had like a couple of years ago were not available, and now they are. A new wire technology, new stent platforms, new micro catheters. They're completely, the innovation is ongoing, and we need to stay updated about it. And now the pandemic has stopped. We are able to see each other in person again and stay updated, not only virtually, but also in real life. So get familiar with the tools and the skill set you have. And with that, I'd like to close up this session, thanking ASAHI, thanking Kambis, thanking Greg, and thanking the audience for attending, and hope everybody to see each other again real soon.